Okay, we're going to start talking about suctioning of children and infants and the differences between what you may see at a hospital but what you're going to see at Hilltop and home. The first thing that I want to point out to you is that you are not going to be doing suctioning with the long suction. We're going to talk about how you're going to clear out the trach opening itself without inserting this. A couple of reasons for that. We used to do this, but you would have to do it under supervision. The respiratory therapist at Hilltop will come in tubes mixed up. Will come in and do deep suctioning for some of the children that have had albuterol and then been put in the vest, and she will come in and do some suctioning. Now there is a warning about infants in suctioning, and that is in your textbooks you are told that you insert the catheter till you hit something solid, which would be the hyoid bone. Then you pull back before suctioning. I'm not reviewing the whole method of suctioning right now. I'm just telling you why you're not going to be doing this. So if you were suctioning a little infant and you just put this down until it stopped and you hit something and pulled back, you are causing tissue damage to a growing child, especially if it's an infant or a premature baby. And that can lead to tracheal stenosis. In fact, there are children that have trachs that are only because they develop tracheal stenosis. And when a child has that, have to wait until they grow large enough and their trachea gets a large enough airway, and then you're going to be able to decannulate the child. So that's a good reason for us not suctioning babies right now until you're more experienced. There is another difference in children that have had trachs at home than what you've seen with adults in the hospital. So for adults in the hospital, mostly they have the inner cannula that is disposable, that you clip out, throw out, and get a new one. In children, and especially that have chronic trachs, they have a very flexible one-piece type of trach, similar to this. There's no inner cannula. Okay. These are, of course, non-latex, fairly flexible and soft. The important things about these are that they are numbered. So this is 4.0 peds. The millimeters and the lengths are all on this little tube, which wouldn't concern you too much because you're not going to be changing these out. But this is valuable information if you are in a setting where you're supposed to have the smaller and the larger trach here. Kids at Hilltop probably have a pretty good, well-developed, well-matured opening if they lost their trach. Be fairly easy to put it back in, but it's always good to know about having the smaller trach. You may see this in a room, especially in the hospital. The obturator is supposed to be at the bedside. The purpose of the obturator, of course, as you know from adult trachs, is to reinsert the trach if it comes out. So there is a rounded point at one end that helps to guide the trach through. The other thing that's important here is this is a 4.0 obturator and it's marked. This is a 4.0 peds and diameter. So we have the correct obturator here and the correct trach. Just to add to the base of your knowledge, you will not be having to change trachs on your patients. Okay. I wanted to show you there are smaller little bitty trachs. This is a neonatal trach, and you'll see it says neo on this side. And then your width and your depth or your length are over on this side. So you'll even see smaller ones of these if you work in a NICU situation or whatever. Okay, so what you are going to be doing